Hello, good evening, everyone. So, as we celebrated the International Women's Day over the weekend, I welcome you to yet another podcast on the 10th of every month as I come. And on the 10th of March, I have the privilege to welcome a very celebrated speaker, Professor Siladitya Bhattacharya. But before we take on to this podcast, let me express my thanks and gratitude to our dear president of the Fogsi, Dr. Sunita Tandulwadkar, whose genius has blossomed and grown this podcast into the 41st episode. She's allowed us not only to dwell us on the health technologies that have advanced over the years, but also allowed us to cross boundaries to dwell on social, economic, psychological, and political issues that impact women's health. We know globally we are shrinking. The total fertility rates are declining. I think total fertility rates across the globe in the last 5 decades have declined from 5 to close to 2.3. India also has shown a dramatic decline in fertility rates, i.e., the number of children born to a woman in the reproductive years, looking at something from 6 in 1950 to 2.2, 2.3 as projected in the National Family Health Surveys. So, to dwell on this declining global fertility, I have a very celebrated speaker from the UK, and I take this opportunity to introduce Professor Siddhartha Bhattacharya, who is currently the Vice Principal for Global Engagement and Sir Dougal Byard Chair in Women's Health at the University of Aberdeen. After graduating in medicine from the Calcutta University, he moved on to UK for his postgraduate training, spending his years in some of the best centers in UK. He completed his subspecialist training in reproductive medicine and clinical research, and then joined as a lecturer in the University of Aberdeen Medical School, the Grampian NHS in UK. And ever since then, there has been no looking back. He rose to the post of the head of department of OBGYN at the University of Aberdeen. He has been the he has taken previous appointments, which include the head of the medical school at the University of Medical Science in Cardiff. Then went on to become the head of medical school at the University of Aberdeen, Medical Science and Nutrition. And we know his prolific interest in research span reproductive epidemiology, health technology assessment, and he's been a very decorated researcher whose publications have found place in journals including the Lancet, the NEJM, to name a few. So, moving ahead, I think I'll welcome Professor Bhattacharya. Good evening, good afternoon, Dr. Bhattacharya. So, welcome to this podcast.
Well, good afternoon. It's a great pleasure to be here, Nina. Thanks so much for inviting me.
And I would like to say here that he has mentored many of us, including me, who have taken his, learnings and have moving forward in our career. So thank you so much for joining. I think we'll start and move ahead because if we go on talking about you, we're going to spend the whole time because your CV still is incomplete, and we can talk on it as we come close. So, Prabhati, what do you think is the current trends as we see that there is a declining total fertility rate? Do you think we should get concerned about it when it is on the global front and in particular about India, given that we are a largest, you know, country as far as population goes?
Indeed. Well, I don't think we need to be in a state of alarm over it, but I think we certainly need to understand what it means and take appropriate measures if we are looking at this as a global issue. Some of the data around total fertility rates are, as you've summarized in your introduction. I suppose some people might be a bit concerned if they look at some of the projections. And I think we are both quoting the same paper, which is the Global Burden of Disease Lancet paper published in 2024. And of course, the more sensational headline there was, at the moment, I think around half of all countries have a total fertility rate which is below their replacement minimum of 2.1.
Wow.
And if we look ahead to the start of the 22nd century, there are only likely to be 6 countries with fertility rates above that replacement level. And I think before we get in a state of panic about it, I think it's important to understand it in context, which is, of course, much broader than a simple medical issue. And at the same time, given the audience that we have today, it's important to make a distinction between infertility as a medical construct, which is the inability to conceive after 12 months of exposure to pregnancy, and total fertility, which with the definition of which you've explained earlier, which of course brings in the concept of voluntary infertility or delayed fertility. So the drivers for the drop in total fertility rates go beyond medical causes, and the key elements there are socioeconomic, particularly education, women joining the workforce, the ability to plan pregnancies through contraception, and indeed societal perceptions. In some cases, there are obviously government interventions, as we've seen in China with the one-child policy, but it's a much broader concept. Coming back to
Yeah.
your point, whether we should be concerned about it, I think as scientists and as human beings, we need to understand what these data mean, and we need to make appropriate societal adjustments to deal with it.
So if we were looking at the next 75 years, maybe 2100, where do you think these fertility rates would take us? To below 1 in India, or you think we're going to be somewhere closer to 2 or replacement rates?
I think given the current projections that we see, you're certainly within India likely to see significant falls. And you can already see that if you compare urban and rural total fertility rates. If you do the associations with female education, literacy, women joining the workforce, I think you can do your own sums.
Yeah.
It's interesting to see how China has gone through its population profile, and particularly its demographic structure over the last 4 or 5 decades. And it's certainly not an accident that India has overtaken China as the most populous country in the world. But in the same way, and that we have opportunities opening up for women, uh, literacy levels rising, and prosperity growing, there's an inevitability about how that then is accompanied by a decline in fertility rates. And you don't need to look very far. I mean, if you look at Japan and South Korea, Japan has a total fertility rate that is quite close to 1. I mean, South Korea almost dipped below 1 at one point. It's only shown slight signs of recovery over the last couple of years. And both countries have very strong pronatal initiatives.
Yeah, thank you so much. And I think I would share that, in India, in the state of Sikkim, which is a real cause of concern, the fertility rates are as low as 1.1, even below the replacement rates. So I would just say, do you think that these kind of figures, as we look at numbers, as you rightly say, are they going to be affecting a woman's health, particularly, contributing to our, declining fertility as well? Or you think that a declining fertility is something which is a different issue? How would you kind of look at both these? Because
I
there are all
think I
data
think
which says there's a
I
rising
think
infertility in India, and that's again
I
a
think the
projection which is,
data, I think the data around infertility are more complicated and therefore contested. And that's primarily because we've not been, as a professional group or as a society, been particularly successful at defining infertility. And most of the published literature on it, I think, can be criticized on the basis of the heterogeneity of definitions used. Again, if we go back to the Global Burdens of Disease project, and remember that was the data set in 2021, from which we still see papers emerging. There's a recent publication, actually earlier this year in Human Reproduction, that looks at global trends in terms of this time, not total fertility rate, but infertility, but using the same data. And that suggests that if you look at age standardized prevalence rates across the world, there is evidence of a decrease. Now, before we get too carried away by that, I think it's important to put that in context. And previous work on infertility rates have not necessarily shown this. So this is relatively new as a development. The
Okay,
distinction between total fertility rate and infertility per se, obviously, is the voluntary element. And of course, there's a crossover between the two in terms of delaying pregnancy to the point where age may perhaps becomes a barrier. And that answers your question as to what could be potential causes for some of this infertility that we see, and particularly infertility that's been captured in a publication such as this. But there are other causes, because if you look globally, depending on which part of the world we look at, there could be other health-related causes such as pelvic infection, and that could be in men as well as women. But certainly in the more economically developed world, age seems to be a major factor in higher numbers of women attending fertility clinics. That then links on to the next question that you raise, which is, does it have an impact on health? And the obvious impact then is if the age at first pregnancy is that bit higher, and more stark, I think, is if access to assisted reproductive technology opens up opportunities for pregnancy in women with a number of comorbidities, then infertility is linked indirectly with general health.
so I think there's what I get a message that there is a delayed parenthood, which is kind of having an overlay on declining fertility. So age is something which is kind of with women pushing their reproductive, parenting and childbearing to later years is probably a cause of concern. So, do you think that male factors or the male fertility is a contributive factor to declining fertility or delayed parenthood as well? Or it's like just the women to say that they are the ones who are moving aggressively in their career paths, or I think parents or potentially couples see that they have IVF as an option and therefore they're taking that as a kind of excuse to delay parenting. How do you feel about that?
I
The
would
men.
I wouldn't call it an excuse necessarily, but I know what you mean. Well, again, if you believe these data from I think the Global Burden of Disease data set, they've certainly looked at male infertility and they've seen a decline there as well. But as we all know as a community, and that includes the audience here, it isn't necessarily always a male or a female element. So I think we need to look at it in context. In terms of whether this is a problem, I think what is a problem is, I think, a belief that IVF, if we're going to call it that, offers an instant solution. And I think there is perhaps a slightly naive belief in the power of technology to rescue us from the consequences of delaying pregnancy, or simply the reality of the current social situation where a couple feel that it's the responsible thing to do to wait for the right time to bring a child into this world. But of course, when everything else fits into place, then sometimes it's difficult to conceive as quickly as you otherwise would.
Yeah, I think you really pointed out, the naivety on falling back on technologies. So, I think we again perhaps paying the price of getting more modernized, Do you think this changing societal behavior, the societal norms, or perhaps our changed lifestyle has is a bearing on fertility for couples? How do you see that trends in India? Because uh, how do you see that, having worked in India and then you move to UK and you do see Indian society? How do you see that as a potential reason for affecting
Well, I
fertility?
don't know the data for India as well as I do for the UK. For India, I suspect there are huge regional and urban-rural differences. But I suspect, and I'm speculating here, if you look at a purely urban population in some of the bigger cities, you probably have noticed maybe a slight delaying in the age at first childbirth in a section of the population, although that may not be universal across the whole population of women. I think the Office of National Statistics in the UK has demonstrated that a few years ago, we reached a milestone in which the age at first childbirth went well above 30 for women in the UK. So there is that. In terms of other socio-economic, environmental factors, I think now we're in the realms of speculation. We certainly know about the impact on behavior. What we know less well is about the impact on fertility per se. And every now and then, all of us will have our attention drawn to papers that seem particularly interesting, mainly because of the headlines which are striking and often go on to say that sperm counts are plummeting or that
Mm-hmm.
environmental factors are eroding the natural fertility of men and women. How these are all observational studies, and they need to be because of the nature of the question. But they all come, I think, with a number of health warnings, literally, just because of the uncertainty of the field and the way both the exposure, i.e., the environmental factors, and the outcome, which is fertility in this case, are measured.
Yeah, you rightly said. Rob, what do you think? Practicing. You've been, practicing fertility, subfertility, infertility in the UK for the last 4 decades. And again, here in India, we're seeing a rise in women who come with premature ovarian insufficiency, i.e., ovarian, declining reserves. And I think we do get a little, anxious when we see a lot many younger women come as surprises with, lower ovarian reserves, or they're being pushed. So, how is your experience since you've been practicing for so many years in the UK? How do you see the trends there? Are you seeing there is a change, or you feel, because if I look at it, in the last 20 years, when we saw just 10 to 15% coming with a reduced, ovarian reserves, now we see a higher number of women, particularly the younger women. How do you see these statistics, and how do you feel that there is a difference or a paradigm shift in the patient profile who are seeking services for ART in the UK, as we see in India?
Well, I think we are all aware that we are seeing women with low ovarian reserve in our clinics. Whether this is a paradigm shift on our part or a paradigm shift in biology and physiology of the women is an unanswered question. I think the bias here is that of ascertainment. So, how many women in your clinics were subjected to tests of ovarian reserve 20 years ago? Very, very few, I would imagine. Whereas now it's ubiquitous.
Yeah.
Again, do we have a comparator group? How many fertile women do we subject to tests of ovarian reserve? Because if you did, if you only manage, if you manage to compare a like with like populations, that you're beginning to unpick at this question. So to me, it's almost a little bit like the fibroid question. When you look for fibroids, you see them. The question is whether they're an association with infertility or a direct cause. Because if you travel to parts of the world where fibroids are ubiquitous, you would expected infertility levels to go through the roof. So I'm talking about West Africa, Nigeria, Ghana. I'm talking about the Caribbean. Every scan that you do will show a fibroid. Yet there is no infertility in epidemic proportions. So again, the question then is, I'm not denying the fact that we are seeing a lot of women with diminished ovarian reserve, but do we know what ovarian reserve is in a general population?
So you would say, like the fibroid story, which where fibroids could be innocent bystanders, a declining reserve would certainly not mean subfertility or being pushing a woman to ART techniques or maybe giving them just reassurance, or you would say it is an individualized approach and see how the couple takes this because there's so much of
Well,
apprehension in the
well,
family
by the
when
time
somebody comes to you. How do you
Well, by
take
the
that?
time they come to your clinic, remember they're coming to your clinic with infertility. They're not coming to your clinic with ovarian reserve problems. So what I'm trying to do is disentangle the two. And if in an infertile woman who needs treatment, you find diminished ovarian reserve, then that is a valid finding and you need to act on it. But I'm, in a sense, doing a thought experiment where would you go out into the general population, screen asymptomatic women for diminished ovarian reserve? And then what would you do? Because the reality is, a number of them might conceive on their own because conception in nature requires one egg to be produced every month, whereas ART and IVF, by its very definition, needs you to push your ovarian response a bit further. So there are two different settings.
Yeah, thank you. I think you really touched the issue. Now, I think we've had a pandemic, I think in our experience of COVID-19, which affected, health across the globe. People had, surprise, hypertension, somebody coming with diabetes. Do you think COVID-19 has had a bearing on fertility, i.e., both for men and women, or you think it just could be some, observational studies? How do you take on that? Because a lot of time people say, blame it on COVID. Do you think we can blame the reserves on this pandemic?
You can only blame so much on COVID, can't you? We've got away for the last couple of years blaming practically everything around us on COVID. I think it's quite interesting that so far the publications, both on men and female infertility, have failed to demonstrate convincingly a lasting and significant impact of COVID on either a male infertility through using a surrogate mark of sperm number and quality, or female infertility in a woman's ability to ovulate. I mean, women who've been temporarily oligoamenorrheic and have been observed over time to see that actually the cycles have returned. So I'm not sure that we are convinced as a community that COVID has led to lasting impact on infertility. And as you know, the recommendation is for women of childbearing age, where appropriate, to be vaccinated. And I think that was the message that was pushed through during COVID.
Yeah, you're right. I think we also published some data on the sperm count. But I think that's interesting. Even if you look at this data, which comes out sort of patients come asking us, we've actually not tested these women before and after vaccination. We've not tested their ovarian, i.e., not even checked the semen count on these men before and after COVID and after vaccination. So I think we can just kind of be speculative and sort of put this in the back burner. Now, I think this was Google, Facebook, and all the employees of those big corporate giants, international,
Yeah.
who are pushing women to kind of, you know, go for social egg freezing and preserve their oocytes in a hope that they could continue with their professional careers. So, do you think fertility preservation is an answer for delayed fertility? In the present day in society, how do you see social egg freezing being taken up
So
globally,
it's,
at
it's
least in
quite
the UK?
interesting you bring that up because amongst the raft of pro-natalist initiatives that people have tried, nations have tried, companies have tried, obviously there are direct cash incentives, economic incentives. There are initiatives promoting gender equality in the workplace as well as the home. There are educational campaigns, but a lot of work's gone into work-life balance kind of initiatives. And I think this falls into the category of companies trying to compensate for the fact that they're actually pushing their employees quite hard. Because again, a thought experiment would be a company that allows women to take a couple of years out to complete their families and can come back unchallenged to the same position without affecting their progress and their career pathway. To me, compared to that, giving somebody an amount of cash to freeze their eggs perhaps seems a little limited in its scope, in its ambition, and indeed in its compassion. So it is
So
a
do you,
step.
sure,
Does
sure,
it go
please.
far enough?
So the assurances, do you think, are being given on social egg freezing to women? Do you think, how should women take that? Because, there are all sorts of billboards across, there are a lot of things going on the social media. It's freezing your fertility, freeze your eggs. Now, how would you take this
I would take
in
it
for
in
the
the
youth?
same way that I would maybe consider IVF as a panacea for infertility. So the reality of both egg freezing as well as IVF is it gives an advantage, and I think most people would agree with that, but it doesn't give a guarantee. In women who are completely, because of their circumstances, whether they're planning to be on the front line, in the armed forces or in space or wherever, and would find it absolutely difficult to conceive. It gives them that reassurance, but it doesn't give a guarantee, because at the end of the day, you can only freeze as many eggs as you can collect. And in fact, a spin out of that currently is egg banking. And we're not going to go there, because that's treatment. It's not necessarily insurance against infertility. Um, as you well know, opinion is divided on it. Where I work, social egg freezing is not covered by the health service, whereas egg freezing for a medical condition, so prior to chemotherapy for cancer, is supported. So I do make that distinction. I also would guard against the reassurance that many people might get when they think that freezing, say, 5 or 6 eggs or 10 eggs or whatever number of eggs are collected, absolutely uh, takes away any pressure on them to conceive in the near future. The risk, of course, as we all know as practitioners, is when the same woman comes back, perhaps at the age of 40, there is a possibility that we might use up all those eggs and not necessarily achieve a pregnancy.
Yeah, I think you really brought up this point very, very nicely and beautifully, that an egg freezing is not an insurance that you may have a child. And I think there are a lot of paper that came on to look at what is the magic number, paper saying that there 15 is a good number. And I think 15 at age 40 would not assure you a pregnancy, or for that matter, even 25 would not be an assurance at the age 42. So I think this is something which we should be, as clinicians, as researchers, and advise women. And I think the downside is that many women may not even come back to use their eggs. So I think we are kind of sitting on filling these nitrogen tanks necessarily or unnecessarily to sort of restore that they could be potentially used in future, because we know that some of these women may actually conceive spontaneously when they find the Mr. Right. And that's what I think. So how do you say about that, Professor Bhattacharya,
I,
on this
I, I,
issue?
I think you're absolutely right there. And there's a sustainability issue here. I don't know what your zero carbon targets are, but we are concerned about lots and lots of cryo storage being used up unnecessarily. I think there is a case for making individualized decisions for people. I certainly wouldn't see it as a catch-all strategy for everybody. I think it's really interesting that all societies like to have lifelines. And I think at the moment there is this feeling, and again, I come back to this naive trust in technology, that there is this perception that the technology that we have is so brilliant that it can cover all angles, and essentially deal with all our potential needs. And the truth is very far removed from that.
Yeah. I'm sure a lot of people should understand the implications of social egg freezing. Now, having said that, there are certain medical indications and situations. So, how do you say and take when they're benign? I'm sure for cancer, we do advise a young girl to preserve her fertility, say, by doing egg freezing, which is a medical indication. What is your take when we see young girls coming up with diagnosis of endometriosis, or there is a benign cyst and she is to how do you see the place or in the realms of science and experience and evidence of freezing fertility in such situations other than malignancy?
I think the list is growing, and we know of where women who have chronic inflammatory conditions are on a whole slew of drugs, many of which are not obviously anti-cancer drugs, but do affect fertility if taken for a while. So I think endometriosis, though, is a very specific situation. And my personal view is that as a group of professionals, we've not really managed endometriosis very well because we place the women that we treat in a position of making an impossible choice because we ask them to prioritize pain or fertility and treat one thing at a time. And our measures of outcome are totally different for these two scenarios. I think the advice that most doctors would give, I imagine, would be to try and prioritize infertility, knowing the natural history of endometriosis. But you're right, there may be some circumstances, particularly if you're dealing with diagnosis in very young women, where there are no opportunities to press on with fertility treatment. The worry, of course, is at a point when endometriosis is diagnosed and it is quite a high stage endometriosis. At that point, we all know of the difficulty on getting a sufficient number and quality of eggs as well. One of the interesting things that might be something to consider for the future, and this is where endometriosis has been diagnosed, but there's no evidence of gross pelvic distortion in terms of architecture, and we still don't have this element of deep infiltrating endometriosis, is some of the GnRH antagonist HRT combinations, which allow people to maybe stop the progression of disease without having to rush into surgery or rush to get pregnant. And I mean, these drugs have been now licensed for use, as you know, in endometriosis. So the question is, I don't know what the situation in India is, whether people are using it, but they do offer women another choice.
I think you really touch this issue because I think endometriosis continues to be such an enigmatic disease, and we really do not know the rate at which it will progress. There's somebody who is in severe agony of pain of endometriosis, and at the time you just harper on fertility issues, may be sort of not taken very nicely. But I think the bit that we have to understand is that, yeah, there will be a decline in the not of the numbers, but certainly the quality of the eggs or the oocytes that we are. So I think rightfully taken a decision has to be individualized, and perhaps these women should be given this option earlier than I would give to anybody else who's actually banking for her career paths or for her social reason. I think that is why. So I think we've really had a nice kind of discussion with you on issues on the declining fertility or for that matter, the delayed parenthood. Now, how do you see the trends in the UK when it comes to social egg freezing, considering that's not funded on the NHS? Are women willing to spend out of pocket as they're doing it in India? Because it's a buzz, it's like kind of, I would say, the game changer in India. How is the society taking in the UK on social egg freezing?
Well, some women are, but I don't know what the situation in India is like. But the pity is, by the time women come with an active plan of egg freezing. They're often in their mid-30s. And I suppose to turn it on its head, if you have to freeze your eggs, you're probably better off freezing your eggs when there are plenty of them and they're of good quality.
So if we're, I know you're not an advocate, but if you were to advocate social egg freezing, what would you think is the right age for these women who know,
Yeah,
yeah,
this gets contentious, doesn't it? Because you're almost willing yourself into a situation where your advice is everybody should freeze their eggs when they're in their early 20s, just in case. But as soon as you think about it, you realize that very few of them are likely to need those eggs. So it's that tipping point between giving women a chance to conceive on their own and not waiting long enough, such that the outcome of egg freezing is suboptimal.
yeah, I think again a very good message coming from you, because when women come to us seeking advice, they're past 37, 38, and I really don't understand. I know that they can afford, they have deep pockets, but is it going to make a meaningful outcome?
True.
Will it give them a baby? Is something which is very contentious for all of us as clinicians. I think we've had a good time. No, I think we've talked quite a bit on fertility. And I think there's something that we have still time to talk to you beyond, science, beyond ART, I think we've seen you grow as a clinician. You've done brilliant, and I think you are a role model to a lot of us, particularly the ones who trained with you. And you mentored so many. So I see your career graph move as a clinician to a avid researcher, and then you go on to be the head of the medical school. And now we see you engaging in a very, very beautiful role as the vice principal of the global engagement. And I just want to ask you, how would you advise the generations that are coming up in medicine? Particularly, we know that the numbers are dwindling. People are not really, enticed, I would say, don't really look up to medicine. But how would you sort of give an advice to the youngsters who are building their career in medicine, A, and B? Oh, well, let's hear this, and then I'd shoot another question later on, similar lines.
I'm surprised to hear you say that people are not interested in medicine, because if you think about it, I mean, there are very few professions where you enjoy what you do. I mean, people who are surgeons will understand, who doesn't enjoy doing surgery? And then, of course, you get paid for it. So, so to me, I think that there is this intense attraction that's very difficult to deny. I do see what where you're going with this. Mainly because medicine has always been an all-consuming profession, and people had to give it their all. There was absolutely no compromise in terms of how it ate into every other aspect of your life, completely dominated your life for decades. I mean, look at this. I mean, we're having this discussion now. It's what, 8:30 or something, local time in
8:45.
India.
Yeah, yeah.
Many people would see this as one of the classic things that are wrong with medicine. This is completely out of normal working hours. And here we are talking about it and hoping that someone's listening at the other end. So I think in terms of understanding how to make medicine more attractive to people, certainly what we've found is we've tried to make the training more user friendly. We've tried to make it more gender neutral. Um, but without losing what's at the heart of what makes people good doctors. So this is the combination of wanting to solve complex problems and compassion. And I think if you put those two together, it brings knowledge and it refracts it through that prism of compassion into what I would call clinical wisdom. And that's something that you gain through years and years of what I would call an apprenticeship process that we've all been through. And part of it, if you try and describe it, is pattern recognition. The other part is empathy. And a third bit is leadership, because it doesn't matter whether you're a junior doctor, you're the head of the department. What you're doing at all times is you're leading a team around you. And to do that, You need to understand how to motivate people, how to bring them on, how to show them this compelling vision that you can see and they want to be part of. And in my experience, most doctors do it remarkably well.
I hope there are some of those youngsters and young viewers who are listening was getting what is called as empathy. I know we have augmented intelligence, we have machine learning, we have all this kind of predictive medicine, but empathy and compassion is, I don't think, can be learned from these kind of new technologies. But I really am glad you've got these issues that we really need to sort of address and sort of tell the younger generations who are sort of looking at medicine not so much as they would look at the other sides of careers, and I would say at least in our kind of younger generations. Now I just have one more question from you. As you talked about the most satisfying profession, where you see that you are maybe a junior doctor or a head of department or whatever you are, there is something like a leader in each one of us, which we really need to do. How do you think you can sort of reinforce to say, yeah, I am a leader? What do you think should be the traits of an individual, or as we grow up in our careers, that say, yeah, you're a good role model? No, you're a good leader, and you can put your unit or your association, your organization to greater heights. How would you sort of advise people in their
Well, I think
careers?
look behind you. If there are people following you, you're a leader. Otherwise, you're a man or a woman taking a walk, isn't it?
So certainly, yeah, I think that's one nice word coming, but I would want you to be a little more, elaborate
Specific.
on.
Okay,
Yeah,
fair
yeah,
enough.
that's
I think the first thing is self-awareness, to understand that everything that we do has consequences. The second thing, I suppose, is to understand people, and something that clinicians can uh, understand and appreciate very easily, that when people don't always say what they mean. So this is how to read people, how to read situations. And whether you call it empathy or whether you call it active listening, I think making shared clinical decisions is really, really important. We all appreciate that. But I think the ability to do that is reflective not just on being an empathetic doctor, but also in practicing evidence-based medicine. Because if you look at the definition of evidence-based medicine, it is using the best available evidence and the best clinical skills available, but it is also coupled with finding solutions that are compatible with the values and preferences of your patients. Just the ability to bring that extra dimension together. So that, I think, defines what a clinician is or should be, but also to understand that we never work as individuals, we work in teams. And that's why the leadership is important. And although maybe people don't see the patient as part of the team, actually the patient is. Because
yeah.
that is the broader mission, isn't it? To find a solution that is compatible with the wishes and preferences of the patients, and then to harness the strength of the full clinical team. So that this is the doctor along with perhaps other members of the clinical team, nurses, physios, um, uh, technicians, to bring together what the patient feels is the best outcome.
Thank you so much for bringing that patient-centered, team-centered approach where we have to make shared decision. I think it's been a pleasure to have you, Professor Bhattacharya. Thank you so very much for enlightening us across the subject and going beyond the subject. I think it's been a pleasure, and we really look forward to you for yet another podcast. Thank you very much, and good evening. Thank you.
Thanks very much. Nice to speak to you and all the best. And thank you to the organizers. Bye for now.
Thank you.